thank Chairperson for your kind introductions. Firstly, I would like to thank Professor Maruyama and the organizing committee for their kind invitations. It's my great honor to present the epidemiology of hepatocellular carcinoma in Thailand. Here is my disclosure. Primary liver cancer, SCC, is the most common primary liver cancer and is sixth cancer entity and the third cause of cancer death worldwide. How about in Thailand? SCC is the second most common of cancer in Thai population and is a leading cause of cancer death, particularly in Thai men. Here is the standardized incidence rate of SCC in Thailand. In general, it's about 22.3 per 100,000 person year, and the incidence rate is higher among men than in women. It's about 36 versus 13 per 100,000 person year. And this is a standardized mortality rate in Thailand. It's about 21.5 per 100,000 person year. It's worth to notice that the incidence rate and mortality rate ratio is supposed 1. That means SCC is the common cancer with the poorest prognosis. Here is the incidence rate of SCC in Thailand, study done in northeastern part of Thailand, but can represent the whole country because the figure show the similar trend. You can see that the incidence of SCC in Thailand declined over time, particularly in the last 20 years. And this probably due to the implementation of universal hepatitis B immunization. We implement universal hepatitis B immunization for the whole country in 1992. And this confirmed by the reducing the prevalence of hepatitis B S antigen positivity in young children who born after the implementations of hepatitis B vaccinations. As you can see that antigen positivity only 0.6% in younger patients who born after implementation of universal hepatitis B vaccination, comparing with 4.5% among older patients who born before the implementation of hepatitis B vaccination. In a similar pattern, look at anticore positivity, that means hepatitis B exposure. Younger patients who born after implementation of universal hepatitis B vaccination had much lower incidence of anti-SB core positivity compared with those who born before the implementation of universal hepatitis B vaccination, 2.3%, comparing with 34.5%. Etiology, similar to Africa and many countries in Asia, hepatitis B is the most common cause of SCC in Thai population. Did look at the cause of SCC in Thailand, study done in 2014. You can see that 40% due to chronic hepatitis B, and if we combine hepatitis B related with all together, you can see that almost half of the SCC Thai patient caused by hepatitis B, and C caused SCC in Thailand in about 16%. And 16% of ketogenic, now we know that 70% of ketogenic is due to NAFO or fatty liver disease. So fatty liver disease become increasingly related cause of SCC in Thailand recently, up to almost 13%. Here is a study of the risk of SCC in chronic hepatitis B in Thailand. You can see that risk factor of SCC development among Thai patients who have chronic hepatitis B infection includes antigen level, male gender, e antigen positivity, and HBV DNA at least or above 2000 IU per mil. These are patient characteristic of Thai SCC patients. I show you the study done in almost 15 years apart. In 2000, that from our own center, and 2014, that from Bangkok. So what you can see, the patient characteristic, when you see the almost 15 years apart, mainly the majority of the patient up to around 80%. And the age of SCC is about 55 years old. What you can see in year 2000, that just 8 years after implementation of hepatitis B vaccination, chronic hepatitis B remained the major cause of SCC up to 72%. But in 2014, that means almost 20 years after implementation of universal hepatitis B vaccination, SCC become less common cause of SCC among Thai patients down to only 50%. And NASH in 2000, because that time we didn't know much about fatty liver disease, but in 2014, NASH contribute to 11% as a cause of SCC among Thai patients. Look at the clinical feature. More than half the patient have hepatomegaly, and about 1/5 the patient to 1/4 the patient also presented with the cirrhosis related symptom. What I would like to draw your attention is that in 2000, only 2.1% are asymptomatic. Comparing in 2014, almost 25% were asymptomatic. I think this because of the surveillance program. In year 2000, the surveillance of SCC is not really common practice among non-hepatologists in Thailand. So therefore, the patient will be sent at the later stage and unlikely to be asymptomatic. Comparing with 2014, when SCC surveillance program become more common and is universally practiced among GI doctor or hepatologist, you can see you detect earlier state of SCC. Therefore, almost 25% of them can be asymptomatic. This state of SCC at the first presentations. In Thai populations, 1/3 present at the intermediate state or Barcelona Cancer Liver Clinic staging state B, and 1/3 present at the advanced state, BCLC state C. You can see early state seen in only less than 15% of the Thai patient at the first presentation. So that means most of the patient, at least 2/3, present at the later state of SCC, either intermediate state or advanced state SCC. And again, comparing the state of SCC in year 2000 and 2014, you can see after universal SCC surveillance program implemented in many medical centers, you can see that you see earlier state being detected at the first presentation more than year 2000. You can see up to 25% of the patient due to SCC surveillance program can be diagnosed at the earlier state, either state 0, very early state, or state A, that's the early state. However, bear in mind that about 25% of patients still able to present at the terminal state of SCC. That means we need to educations and also promote the SCC surveillance program. Talking about SCC surveillance program, this study done in Thailand, you can see these are patients who are under SCC surveillance program, comparing those who are not in the SCC surveillance program. Those patients who are under surveillance program has a better survival than those who not in the surveillance program. So because surveillance program can detect at the earlier stage and still able to undergo ablative or curative therapy. We also did the study on co-effectiveness of SCC surveillance among Thai patients. These are willing to pay about 160,000 in Thai currency, but we found that a semi-annual ultrasound, that means ultrasound every 6 months, is the most cost-effectiveness for SCC surveillance program in Thailand, and followed by ultrasound every 6 months plus alpha-fetoprotein. Therefore, in Thailand, we recommend either ultrasound every 6 months with or without alpha-fetoprotein in the standard SCC surveillance program in Thailand. Did look at the insert for semi-annual ultrasound. You can see that surveillance program in patient age between 35 and 50 years old is very acceptable and cost-effectiveness for SCC surveillance program in Thailand, and show that patients who are under surveillance program had the better survival. You can see the patient under surveillance program have 37% risk reduction of mortality compared with those not in surveillance program. Regarding tumor marker, alpha-fetoprotein is the most common use of tumor marker in Thailand. We just recently in last 5 years used the PICA2. What I would like to draw your attention is 2/3 the patient of SCC patient in Thailand have alpha-fetoprotein above 400 nanogram per ml, but 29% can have alpha-fetoprotein below 200,000 nanogram per ml. So alpha-fetoprotein alone is not good enough for Thai populations. In Thailand, we developed our own Thailand guideline for management of SCC in 2019. We also follow the modified BCLC staging, because this one can predict the prognosis of the patient and also allow the strategy for the treatment according to the state of the patients. I just want to touch on liver transplantation. Liver transplantation in Thailand, you can see this done in Thailand. If we look at only Milan criteria, of course, patients who have liver transplantation within Milan criteria had the better patient and disease-free survival than those who transplant but are outside Milan criteria. However, only less than 10% of the Thai patients are in Milan criteria. So if we want to do the transplantation for more SCC patients in Thailand, so why we extend to UCSF criteria, you can see transplantation in the patient who within UCSF criteria still have quite fair long-term survival and better than those who are outside UCSF criteria. So when we look at 1, 3 year and 5 year survival of the SCC patient who have liver transplantation in Thailand, you can see outside Milan, but still within the UCSF criteria among Thai patients, the long-term survival is fair enough, and it's far better than those who have liver transplantation and are outside UCSF criteria. Mr. Chairman, ladies and gentlemen, I would like to conclude hepatocellular carcinoma is the most common of cancer and is the leading cause of cancer death in Thailand. Universal hepatitis B vaccination program started in Thailand in year 1992, resulting in reducing prevalence of chronic hepatitis B and SCC in young population. Chronic hepatitis B is the most common cause of SCC, but SCV-related and NASH-related SCC are increasing recently. SCC surveillance program with ultrasound biannually is cost effectiveness, leading to early detection of early stage of SCC and improvement of patient survival. Extended criteria to within UCSF criteria for liver transplantation in the patient with SCC is quite acceptable with a fair long-term prognosis in Thai patient. And I thank for your attention.